Thank you, everyone. It has been, as Dr. Hargarden said this morning, this is indeed like a paradigm shift for us to begin to look at firearm violence and firearm injuries in a way that we look at other diseases. And I would also say that there's also a gap in the way that we look at other diseases, quite frankly, even the model that we use, because we're taught in school, in medical school, to address acute things, address what's in front of you. They don't necessarily ask us to focus on the root cause of it and how it happened. So we all wind up treating things and inadvertently sending them back to the things that actually caused them. So I think we can begin to address this issue as in a medical model, but an enhanced medical model. The other thing I would just say to begin to recap the day so far, which is probably the most difficult task of anyone today, but very interesting all day long. Some of the themes that came up for me, one of the major ones is like intersectionality, I would say. The intersectionality of firearm injuries and firearm violence to other things that people from the different panels alluded to, like root causes in the community, for example. How do people, when you look at the spectrum, I think Terry put up a slide that showed pre-injury, peri-injury, and post-injury. And what are the things that happen pre-injury that sort of led to the next step, that led to the injury, and then what things have to be in place after that to address it, to break the cycle, to eliminate the gaps, all the things that led to that. So there's the intersectionality of communities, and I think the very first panel actually looked at that and looked at what is the toll of individuals and communities. Well, some people say now that your zip code impacts your health more than your genetic code. And so what are the things that exist in your community that contributed to these injuries that people wind up having? And then once a person has an injury, as the pediatric surgeon showed, how does that impact their life, their family's life, and the people who are around them? And what are the things that we can put in place to address that and mitigate those effects? And then there's a theme of behavioral health as well. Where are there opportunities to address behavioral health, and where are the opportunities to address the things that sort of like lead to it? Where can we identify risk? And what can we do to do that? And how can we train providers to have the confidence to assess risk? And what would that take to operationalize that, both in the healthcare system as well as for individuals? And so I think there were a lot of different themes that came forth, and then some of the interventions that exist, and then research. There's been a lot of robust research going on, but I agree with Megan Rainey. I love research. I really do. I love research, both qualitative and quantitative, because I think they inform each other. But at the same time, I won't say but, I'll say and at the same time, I like to use that information to implement things, to have impact, and then measure the outcomes. I just want to mention one last thing about the qualitative information. Terry talked about this, about some of the comments that people made in the paper that looked at why black males who are victims of violence would participate in research. And sadly, it's because it gave them an opportunity to have human contact, which is really, really sad. And I would say that that kind of information, for me, at our hospital, we have a violence intervention advocacy program, and when we started that program, it was the tattoos that the victims of violence have on their bodies that I would see when they would be in the trauma room that informed me and instructed us in what would be the basic, the foundational elements of creating a program that we thought would have impact. So the tattoos would say things like born to be hated, dying to be loved, or living is hard, dying is easy, or death is nothing but to live defeated is to die every day. And so we thought about what we would do to reverse that notion for those people in their minds. You know, they felt like there was no place in this world for them, or certainly in this society, and so we wanted to provide hope for them. But hope in more than being aspirational, but providing avenues for them to actually alter their quality of life course. So addressing a couple of things that have been mentioned here today, the intersectionality of all these things. So we do address the social determinants of health, but we work in tandem with behavioral health clinicians, and we address that at the same time. And we provide behavioral health for the family members and other people proximal to the victim. So, and we have a workforce and a housing track in the program. So people have an opportunity to get career-type jobs and have safe housing to do that. These things sort of resonated today. Everything has resonated because, after all, like a lot of people, I'm in emergency medicine physician, and that gives you a unique glimpse into human nature, the human condition, and all what constitutes life.